answers to your ACL injury questions. I'm joined today by Dr. Grant Garcia from the Orthopedic Specialist of Seattle. I am Mitch Owens. I'm your host today. I'm the owner of Union Physical Therapy. We're a small physical therapy practice in Seattle. We specialize in treating the outdoor adventure athlete. And so that's a population of athletes we like to call the Northwest athletes. These are folks who ski, bike, and climb, and just generally like to get out and enjoy and recreate in the mountains. So we see a host of sports-related injuries, and for these individuals, these sports are their passions, and they are life sports. These are things that keep them engaged with their community and really bring them a lot of joy in their life. So there's a lot of motivation to get back out there, and that's a big emphasis of what we're trying to do at Union Physical Therapy, which I should mention that I co-founded with my wife, Elisa Owens. And I'm also the co-founder of the Alpine Training Project. We are a online web-based ski and snowboarding conditioning fitness program, essentially, where I'm joined by two other physical therapists, Mandie Majerus and Kristen Vaughan. Mandie is part of the U.S. ski team medical pool. So she's obviously a great resource in understanding injuries that are unique to skiers. She's an amazing endurance athlete herself. Kristen's a free ski competitor. And myself, I'm a backcountry snowboarder skier. And so a lot of years of experience in the field, but also a lot of experience rehabbing injuries. So we put together the Alpine Training Project, which is essentially a training platform for individuals who are looking to prepare for the season and reduce their chances of injury. And it's all evidence-based. We're utilizing some of the evidence that we're going to talk about in today's presentation. So joining me today is Dr. Grant Garcia. Dr. Garcia is an orthopedic surgeon who's fellowship trained at Rush Medical Center, who completed his residency at the Hospital for Special Surgery in New York. Dr. Garcia is a Seattle native, and we are very fortunate to have him just right down the road from our practice. What a resource for our patients and our community. So with that, I will go ahead and kick this presentation off. And essentially the format for today's talk is we'll be going through and just doing a question and answer format here. The idea was to pose the questions to Dr. Garcia in a format that essentially would be the kinds of questions that a patient with a new knee injury would have, who's going on to do a little bit of Dr. Google reviewing, and we want to try to give them the best information that we can and provide some resources for them that will hopefully guide them in their recovery process and some of their decision-making process as they kind of wade through all of the options that are available out there. So with that, I'd like to just start things off with, how does somebody know that they've had a significant injury? When do they know they need to start conversing with someone like Dr. Garcia or myself? And so after somebody's had an injury like this, they've had a rotational knee injury, they've strained their knee, they sprained their knee, what would be some indications to them that they may have possibly injured their ACL?
I think that's a good question. And, you get some of these randomly people ask you, my knee hurts, should I go in? Those type of things. So this is a good question that I get from patients. I would say the biggest thing is swelling, especially for an ACL tear, if we're going to talk more about those today. If you're skiing, you feel a pop or a twist or something like that and your knee swells, the data shows around 70% of those are ACL tears, still proven otherwise. So it's pretty important, if it's got that much swelling, you should come see somebody, because initially when you tear your ACL, it bleeds and the bleeding can swell up your knee. And so you might not feel unstable, but you'll feel that swelling sensation. So you should probably have someone take a look at that, especially if you're a younger, more athletic patient, because that's probably the first time you'll experience that swelling. The next thing I'd say is if you feel unstable, if you, and that's a hard word to describe because everybody thinks about it differently. And until you feel it, you don't really know what I'm talking about. But once you have that injury, and if you're sort of stepping or walking, you feel like your knee's going to shift out of place, or it doesn't feel like you trust it at all, and you're an active, healthy athlete, that's when it's time to have someone take a look at it. And I think that it comes from 2 days. I mean, you should go to union PT first. I mean, I always send people to PT after an injury. So even if it's something that doesn't require an orthopedic surgeon or surgery, you can go to the PT right away. And that actually ends up being a really good source that sometimes they can tell you, is this the right thing to do? Should I wait on it? And if there's a problem, then they'll send them to me. But either way, we're happy to see you. But the PT is really important.
Yeah. How important is that pop, that people will describe, or maybe they felt it, maybe they didn't? How strongly does that correlate to injury?
It's pretty strong if you feel the pop. But I would tell you that in my practice, I mean, just ski injuries I've had in the last 3 weeks, it's not as common as we think. I mean, I would say initially, first started seeing patients, we thought maybe we'd see it like 80% of the time. And I always ask them, did you feel a pop? It's probably 50-50, maybe a little less. And there's not a lot of good data on that pop per se. But I would say that's sort of the people that feel it. If you feel that pop, that's generally the ACL.
Yeah.
But again, we're going to go into this, but I don't give I try not to overdo the information with patients when they first see me until I have more stuff to evaluate, because you also don't want to add worry when it ends up being not as big a deal as we thought. So, but a pop is concerning and swelling is very concerning. And those are the two first things someone will have. And usually it's skiing or some high pivoting exercise.
Got it. And the swelling comes on pretty quick, right?
It's usually it's within a day.
Mm-hmm.
When someone says it started swelling 5 days afterwards, I don't really get as much concern, because remember, it's a tear, and then the ACL bleeds because it has a blood supply, and so that bleed, it's not a very big space, so it fills up pretty quickly.
Mm-hmm.
So usually within 24 hours. The biggest sign to me, and I ask this question of literally everybody that comes in with skiing injuries, is were you able to ski down the hill? Mm-hmm. 9 times out of 10, they could not finish the ski run. I remember a few guys have had it. One was a professional, like he did all this teaching for skiing. He skied down with one leg.
Yeah.
But that's pretty unusual.
Got it. Yeah, that's a great thing to throw out there, right? Easy question to ask patients, easy to ask yourself. And so the extent of the injury, is that going to correlate to the extent of the swelling? So if somebody has like a partial tear versus a complete, is there any guidance on that?
There is some. I would say it's not well correlated. I mean, I saw 4 partial tears in the last 3 weeks, mm-hmm. and 3 of them had really bad knees that I thought had a full tear. Mm-hmm. And so even with my ability to do the diagnostic stuff and everything else, we still can't fully pick up on a full or a partial tear initially with that first injury, because they're pretty stiff as well. So they do get some tearing, but it also depends on the amount of tearing. It's just like a piece of paper, right? If you have a partial tear of it, but you just tear a little bit of the piece, versus you have a partial tear and it's almost all the way full, that's still considered a partial tear.
Sure.
Right? So the answer is, if you damage the blood supply, and that's also when we get more concerned, is that person going to be able to cope, which we'll go in. I don't want to steal your thunder, but we cope at some point and talk about it.
Okay, great. Well, so somebody has swelling, they can't finish the ski run, they heard a pop. You already stepped into this a little bit, but what do you think the best next step would be? And then when should they come and see you?
I think the next step is a couple things. I mean, I think there's 2 modes. Obviously, most people in Seattle area are very active. They're very in tune. They're very internet oriented. So they find somebody that can take care of them as quickly as possible. So they're either coming to see me right from the injury, but I would say about 20 to 30% actually go straight to the PT, which is great. And they utilize them. And I've had a fair number from Union as well that are good diagnostically. So the answer is, like, you can go either person. I think the PT gives you a jump start. You might not know as much information because you're not going to get the next set of imaging, but that PT is so essential to start. I mean, the number of people I see that come in with like a locked in brace for 4 weeks and then they finally see me, those are a shame, because they get a little delayed if they need something in the future. But I would say coming to see the orthopedic surgeon if you feel that injury is a great idea, or go to your physical therapist and they can help you out too, because sometimes they can avoid you having to go to multiple doctor visits or go through all that stuff when they say, the swelling's actually not that bad. Let's just sort of see if we can rehab you for a few weeks.
Yeah, great. And so once they've decided to go get care, whether it's PT and we refer them to you or they come straight to you, how are you going to make that diagnosis?
So it's a combination of things. I mean, there are a fair number I can make clinically. So I do, a number of different exams, which we're not going to go through now, but and I have little tricks for when people are stiff or they're a little bit nervous, because everyone's nervous if you injure yourself the first time. And so it's usually clinical diagnosis, but then, we're going to probably go into other questions with this, but the next thing is we usually get an MRI.
Great. And then how reliable are those MRI findings? How consistent are the findings? And what are you seeing when you're looking at an MRI compared to what you see when you go ahead and you're doing surgery on the knee?
That's a great question. So the one thing people have to understand is it's not perfect. So a big, bad, fully torn, spun up ACL tear, that's easy. You see that on the MRI. You can see it from a mile away if you've done enough of these. Those are straightforward, but not all of them are like that. And so you have to really be looking for other things like bone bruises. And that means that the knee, when the ACL tears, kind of shifts out of place, knocks together, and then comes back. Obviously, it's milliseconds. But that bone bruise, you don't even need to see the ACL to know that happened. And so those are the things I'm looking for on the MRI that give me the sort of pathognomonic information of the ACL tear. And so I would say reliability is quite high when it's a bad tear. The problem comes in when it's a partial, because I can see signal throughout the ACL, but sometimes it's hard because some of these people are really good athletes. I mean, especially in Seattle, we have some really good skiers, really good athletes that are able to compensate well, and they actually may have had a partial already. And so, you want to make sure you don't tell someone, you need surgery or you don't need surgery or whatever, if it was an old injury versus new. So there's certain things I can take a look at. I'd say the number one factor for me is the bone bruises, and the second is looking at the ACL itself. But it's pretty good. I mean, I would say that out of 100 people, let's say I'd see with an ACL injury, there's maybe only a few where the MRI is not as helpful as I'd like it to be.
Got it. And on your clinical exam, do you have favorite special tests? What do you like to go with?
Well, so everyone always talks about there's a bunch of special tests, and they talk about the pivot. The answer is good luck getting someone to pivot after you've had a ski injury in the second day. I can tell you this, I do a lot of pivots. I would say I'm a professional pivoter, and I really can't get a good pivot on a person that just injured themselves skiing. It's the same way with any of the, we've taken care of NFL players on the field, and you run out there and you see those docs do all the little tests. You can ask them, and I've done it myself, you don't get much.
Yeah.
Everyone's not happy with that test. The one I like is the Lockman. I like to put the person's leg on there. I usually put my leg underneath their hamstrings to really get them to calm down. That's the trick with someone who has a really sore knee that's really worried about you doing that, because they obviously know, I know what I'm going to do, and they know that I'm going to test it in a spot they're not comfortable, because obviously they know they're injured. And so that's really the trick. And I do a Lockman and really checking to see how much draw or how far that tibia or that leg goes out forward, because that's one of the restraints of the ACL. If that's positive, I'm telling them I feel confident, or I feel that, there's probably some concern about your ACL, and then I get the MRI. But there's a very few people that I'll see after a ski injury that I won't recommend the MRI, because here's the thing. You don't want to miss a meniscus injury in like a 20-year-old and tell them to keep walking it off. And it's such a low morbidity imaging study. Obviously, we don't want to waste resources and do all those other things. But for our active population, you come into my office, you've already bought yourself that in some situation, because there's obviously a concern. And when they're referred by a PT, it's almost always to get an MRI, because you guys have already done a great exam on them, and we're both concerned at that point.
Yeah, great. Well, so go back to our scenario. We have our skier. They've had that rotational injury. They're swollen. They heard the pop. Couldn't ski down. So, what is the best case scenario that person is looking at, and then what's the worst case?
So I don't want to go in too much in the weeds with other injuries, but because we're talking about ACL tears, but it's really all about skiing injuries as well, since we're kind of going on that topic.
Yeah.
And you guys see so many skiing injuries. Best case scenario is obviously nothing, but the best case scenario overall is an MCL tear. An MCL tear, isolation, those heal up really well. Very rare that you need surgery for that. And I see those every once in a while. I would say 1 out of 10, 1 out of maybe 20. Second best case scenario is a partial ACL tear. And then we'll get into sort of like what may need surgery at some point and what's the best case. I think that's what we're kind of getting at, right? So a just isolated ACL tear, young, healthy patient, no meniscus damage, no cartilage damage. And I don't want to go too much into the non-layman terms, but basically you have your ACL and your PCL kind of crisscross like this. The ACL is your main ligament that's damaged. It's damaged 10 times more frequently than the PCL. And that's the one we worry about. There's two cushions in the knee. Those are the meniscus, and those can get damaged as well. Those are the secondary stabilizers to the knee. And that's important to understand because if you don't have an ACL, those take all the brunt. And then you obviously have cartilage in your knee. So that's the soft surfaces you see, like when you have a chicken bone or something, you can see the white stuff. And so best case scenario is just the ACL. Second best is ACL and maybe a small meniscus tear. And in most cases, I can fix that, which is good because fixing means you get back to your normal anatomy. And then sort of worst case scenario, and the data has shown this, is if you have the ACL, meniscus, and cartilage damage. And that's when I start to have to get in my fancier stuff like cartilage restoration. And then, obviously the worst in those is a multi-ligament injury. Means like you've torn your MCL, posterior corner, PCL, all the ligaments. And those are quite poor. Unfortunately, we've seen a few of those recently with the ski injuries. But a majority of my patients are in the ACL and maybe minor meniscus. And so that's a good thing for them.
Okay. And so hopefully we don't see too many of those this year. But let's say we have this scenario where it's a fairly tidy injury, right? We don't have any cartilage damage, no meniscus, no other ligaments are damaged, but we do have a complete tear of the ACL or a significant partial. What are that individual's chances of returning to high-intensity skiing, field sports? What are their chances? How well will they do?
We won't go into too much of the treatment yet, but overall, if the proper treatment's done, let's say they're a coper, which we'll go into, or they're a surgical patient that needs to have their ACL reconstructed, the answer is quite high, but unfortunately it's not 100%.
Right.
And it's all relative, right? I mean, recreational high level, you can kind of tone it down. Professional level, you only get, you don't want, if you notch one below that, you're no longer professional. And so we've seen in the data is it depends on sort of the sex of the patient, so male, female, but overall, high 80s to 90% return to sport. And it's, if you look at the NFL data too, you've seen lots of guys tear their ACLs in the NFL. Not all of them get back, but there are a fair number. And we have more and more sort of innovative techniques to get people back sooner, but never is 100%.
Yeah, I guess I was angling in more to the deficient knee, to that ACL deficient knee. So like, they've got a complete tear, but they don't want to do any intervention.
Yeah. So the answer is it depends on the person. So I have guys that are, unfortunately, and sometimes in my practice, I tend to see a lot more people that can't cope with the ACL being torn just because they kind of get diverted in my section. From the physical therapy standpoint and who you're going to see, if they see me and then come back to you and sort of just treat with non-operative treatment, are that, I can still see, 30% of patients that have an ACL tear that are able to cope with it and they can get back to pretty high levels. It is less common that we see somebody with an ACL tear who's young that can cope really well with high level stuff and they can get away with it. But always the concern is what's the secondary stabilizers, and it's your meniscus. And so maybe they cope with it for a season or two. And we've had a fair number of these come in recently. And then we sort of run into like the 3 or 4 year mark when they want to have something done because something else has been injured. So we got to be, it's a delicate balance. Obviously we don't want to do surgery on everybody. And there are lots of copers out there that can get away without the ACL being torn, but it's definitely a situation we've got to make sure they understand, if you're feeling any instability, you have to come in.
Yeah. And that brings up this discussion of copers, adapters, and non-copers. And with that, I'll just kind of explain what that is and then who is most likely to fall into those categories. So the group that we're talking about here, copers, these are individuals that are going to go back to their prior level of activity without modifications with a deficient knee. Then we kind of start to discuss things in a rule of thirds, and this isn't exactly researched, but this is an accepted idea in the field that basically 1/3 of people will cope, 1/3 of people will adapt, and then 1/3 won't be able to cope, and they'll need some kind of surgical intervention. The adapters are people who are able to reduce the intensity of their activity and adapt to this new functional level with their knee. And then non-copers, those are individuals that will need surgery in order to return to their prior level of activity. And the factors that contribute to being able to cope, Dr. Garcia already mentioned a few of these, but your age and then the intensity of your sport. So if you're a younger athlete and you're in an intense sport, you ski really hard, or you play a field sport like soccer where there's a lot of cutting, your chances of coping go down a bit. If you're a little bit older, you have lower demands, you're more likely to cope. We mentioned kind of the demands on the knee in various sports. So if it's a cutting sport or a sport that involves a lot of quick direction changes or variable surface conditions like skiing, especially skiing in the Northwest, then that can make coping more difficult as well. And then we can sometimes categorize these people actually really early after the injury based on how quickly they return to their previous level of movement patterns. So how well are they controlling their movement? How well can they control their knee over their foot during single leg squat? And generally, how stable does the knee feel? Do they have any episodes of the knee giving way or periods of instability? And then how quickly do they regain their strength? So if you're slow to regain your stability, slow to regain your strength, and you've got a high demand sport and you're fairly young, your chances of coping start to go down a little bit. Also, the other factor that influences your ability to cope is the extent of the injury. Is it an isolated ACL injury, or do you have cartilage damage, a meniscus, or another ligament involved? And then the last thing, and this is straight out of the literature, but are you willing to try PT? So do you want to give the conservative approach a try, or are you fairly unwilling once you know that there's a surgical fix available? And so that psychological piece will impact your outcome and your ability to cope. And then on the non-surgical options side of things, so folks that are leery of surgery or they want to just try to manage without, have we invented the magic pill yet, the magic injection that can somehow bring the knee's function and health back up in the case of an isolated tear or a partial tear on the orthobiologic side of things?
Well, we talk a lot about this because I've done a few talks for Swedish on this, and it's a great topic because everyone's always excited. How can we give you something, inject it into you, and then get you not to have surgery? Because that's everyone's ideal thing. And honestly, you see a lot of injuries, and it'd be nice to find a way to reduce them. Unfortunately, there's a few studies, they're not great, showing PRP injections with ACL sprains. So again, we got to talk about, I know we want to talk about ACL tears, but the sprains are really where the research is, because those are the ones that I almost never say surgery right off the bat. I say, okay, let's take care of this. Let's try to see if you can cope with this sprain or partial tear. And those are the ones we talk about PRP. And there is some data that shows maybe it's a little bit effective, not ideal, but it's worth a try if someone wants to do it. Obviously, there's just a cost involved with some of the biologics. Stem cells, there's not much, and it's pretty expensive. I think, honestly, the best way to cope with an ACL tear is to have a really good therapist. I think you can't make up for that. It's just like a no pill, no quick shot that you can just go, I'm going to go back and do everything I want to do without seeing a quality place like Union and having them take care of your knee. So I think anybody who thinks they're going to get away with just a shot or a quick fix, if there was, then there wouldn't be surgeons and there wouldn't be PTs. So,
right. Well, yeah, there's a saying that I like to throw around. It's for every ligament, there's a muscle, right? And so, it's not as straightforward as, say, in the elbow, where you have a lateral elbow sprain where you can strengthen a very specific set of muscles. It's more complicated with the ACL because you've got a lot more force and a lot more directions to manage. So it does take a very specific approach to the rehab. So now we're talking about these situations where somebody's kind of on the bubble, like surgery, no surgery. What are, in your mind, absolute indications for surgery? When are you saying, like, this is a no-brainer, you're definitely a surgical candidate? and there are some potential downsides to this. I know we've touched on some of these, but I'll give you an opportunity to recap.
Yeah, I mean, if you have injured your meniscus, especially pretty badly, I'm not going to let you go non-operative treatment with an ACL tear. I mean, you're just going to continue to do further damage to your meniscus. And the data, it shows that for every month that sort of, unfortunately, if you delay an ACL and you're not a coper, you have a 1% chance of damaging the meniscus. And so after a year, that's still like 10%, which is still a fair amount. Obviously, a bucketed meniscus, someone where the meniscus is stuck inside, you can't bend your knee, that's automatic, straightforward. I think an automatic, it's hard to say automatic because I really like to give patients the option. I mean, I rarely in my office tell someone they need to do surgery, and I would recommend nothing else. But I would say the athlete, like I want to get back to the sport next year. I'm going to do this level. I'm happy to have the conversation about conservative treatment, but I also get really worried because a lot of athletes are very frustrated if you go through 5 months of rehab and they're not going to get back, and then you kind of tease them along and now they lost a season. So I would say that athletes, almost the one with these high-level athletes that are like college sports where it's a seasonal thing, you have a stronger discussion about surgery. It's the same way with any professional sport. And then those things where you have other underlying injuries outside of the ACL.
Great. Well, for those individuals, I think we touched on this, like, is there any harm in waiting? I think you've addressed that pretty clearly in terms of the risk to other structures in the knee. And so now we've got this person who's, okay, they're off the bubble. Now they're in the surgery pool and they're a high-level skier. They want to get back to backcountry skiing, variable conditions, a lot of reps, a lot of load, doing drops and airs. How long is this person looking at for their recovery, their rehab process before they get back to that same level of skiing? What kind of expectations can we start to build for that athlete?
Well, let me give you the pre-surgical. So you come into my office and then you talk to me. I kind of go through this spiel with you, and I'll make it brief for the purpose of time. Granted, let's kind of rule out no meniscus, no cartilage, just sort of straightforward ACL, which is majority of patients. You're going to be in a brace and probably walking pretty normally out of the surgery center or wherever you have your surgery. And be biking. Probably our goal would come and bike by 6 weeks. Now everybody's different, but that's sort of the rough guess. And then the goal is to shoot for running by around 3 months, and then the PTs will start doing some pivoting things around 4.5 months, and then we start working towards this sort of return to ski. Now, I've had some very above average patients that have gotten back in 6 to 7 months. That's extremely fast. And have gotten back to skiing at that time. But I would say on average, you're thinking about 8 to 9 months. Some surgeons say, 1 year is the cutoff. I don't like to go like that. I use evidence-based. So I'm totally jumping the gun here with the functional sports testing, but really Sure. That's all that matters to me. If you pass your functional sports testing, you can go back as long as obviously you don't pass it like 2 months, which no one does. And that's why I send people to places like Union PT that I can trust, that do all the right tests, that is evidence-based, so that I can feel comfortable letting you go back with the surgery that I did and not injure that knee again.
Great. And then, we know that through the course of their healing, that there's the recovery of neuromuscular function. They can pass all of our sport-specific tests. They can pass all of our return to sport testing. But we know that the anatomy isn't exactly there in terms of healing. And so I was wondering if we could talk about just that graft, that ACL graft, and then we've using this example of our skier who wants to return to sport as soon as possible. Does the health of the graft weigh into return to sport recommendations? How much should that weigh into those recommendations? And then in addition to that, what kind of graft are we thinking about selecting, and what are their options there, and how does that play into their ability to return to sport?
You just opened a Pandora's box with that question. So let's go.
This is what they're doctor Googling, right? It's like, what graft do I ask for, and when do I go back?
If you guys, I will tell you my whole spiel, but on my website you can see I have a video I literally made about grafts, and it goes through each one of these. So my video is 10 minutes. I'm only going to do it in about a minute. Okay, so I'll make it as simple as possible. So first off, health of the graft. Honestly, the grafts, they all change different things with the biologics of them. You have hamstring, quad, patella tendon, and they all have different ways of integrating in. Patella tendon's not, the bone's gonna heal pretty quickly. You've got bone healing now, and then you have to have your own cells. So the way it works is I'll go through the biologics of it. I can't go through each different graft because at the end, that doesn't change my final parameters. It may change what I let them do. So, if someone's had a cadaver graft and they're young, which I don't usually do, but if someone has it and they come and see me, I'm going to be maybe a little bit slower on them because those take longer to integrate. If it's your own tissue, it's a little bit faster. I tend to see that my autografts, which are younger patients tissue from their knee, tend to get back a little bit faster. And I'd like to say it's the graft. It may be a combination, but it's also just because they're different. It's a different physical structure than someone that's in their 40s or 50s that wasn't a coper and had to have their ACL done.
Yeah.
So that's the basics of that thing. I'm sorry, I'm sort of evading your biologics question.
No, that's okay. I guess
I think the graft type is probably asked more than anything I could possibly think of.
Sure.
And everybody thinks everybody's an expert on it, so it's really good. And again, a lot of this is data driven, but some of it's opinion. I will disclose I do every graft option. So I can do hamstring, I do patella tendon, and I do quad. So hopefully my bias is a little reduced. The most common graft you're going to see in the city and in the whole country is hamstring. It's technically a little bit less challenging. And two, that's the most commonly done. So people who learn and train that's what they do. The only problem with hamstring grafts are that the graft is the smallest of all three you get. So let's say I'm not going to go too much in the numbers, but let's say you get most people, especially, active women, men, maybe not like a 6'8" guy, but you're going to get a 7 millimeter graft, and size does matter in this situation. With a patella tendon and a quad, I get about a 10. So you're talking about a 33% larger graft, and the structural support when you actually put all these things together is about the same. And the age difference patterns on the graft too. So I don't want to go too much into it because this is a pretty I like to make it a scientific topic when I decide for patients or help them decide on what they need. Under 35, I tend to lean towards your own tissue. The data shows that does much better than having a cadaver graft. And above 35, 38, I tend to try to do a cadaver graft. Recovery is a lot easier, and there's not really a big difference overall. And that can be debated throughout other people as well, but there's some good data on that. So graft options. So the hamstring I told you about, we do that if a patient wants it. My only concern always is that obviously there can be people, and I don't know if you've seen them in your practice, but they talk about some hamstring stuff that goes on afterwards.
Yeah.
And it's hard for me because I take care of patients from other states that fly in after they've had surgery with somebody else, and then they moved here and they saw me and they've had a hamstring, and I've got to kind of cope with that, even though I try not to do that graft as much as I can.
Yeah.
And so that's the hardest part for me is even when I don't do hamstrings, you still take care of hamstring patients when they have to come in. But it is, and under 25, the data shows if you get a good person to do it that can really make a good job of the graft, you can have reasonable results, but there's other two good options that I really like to do more of. And I'll explain those. So the second one is patella tendon. That's the one that we've all heard about. That's the one that all the NFL players get. And that's the most solid of all three. But everything has a risk benefit ratio. So when you get your patella tendon, we take the center portion of the tendon and bone, and then we do, fixation with screws on that, and that bone heals in. It's the strongest graft that we have. It's sort of when I feel that Lockman, it's by far the most solid feeling, but you have to trade it off for anterior knee pain occasionally. 10% of patients, you guys may see more, but overall it's about 10%, and it does burn out in some people. And then you have to trade off the fact that it's by far the roughest of the recoveries, at least for the first 3 months. The younger you are, I find my patients in their 25 very rarely have bothered by it, but over 25, I've been leaning away from doing that because of those main reasons. High level, like really high level skier, I will push it to patella tendon up to 30, 32, unless someone asks for it. So that's why I always I'll titrate my exam. And the final is the quad. I'm not sure if you guys have seen any of my quad patient, but you've seen some quads overall, but this is sort of the newer cutting edge stuff. We do take the quad tendon, the center portion. It's honestly been one of the least painful grafts. I was surprised when we started doing more of these. And the quad weakness is not nearly as bad as I would expect. And maybe you guys see something differently in your practice with the quad ACLs. It's only about 5% of the grafts used in the country because it's not as commonly of a taught technique, but you can get much larger graft sizes with very little overall side effects. And again, above 25, that's really my go-to now. And it's a little bit faster recovery and less discomfort with similar good results. And again, there will be ad nauseum discussion about this between different doctors. And I'm sure this discussion you're going to hear from me is completely opposite of what some other guy might say. But you always have to take this with a grain of salt, okay? You want to have a good graft done, but you also, in some cases, if you're going to a surgeon that feels comfortable with one graft, he may do the best job or she may do the best job at that one graft, and that'll probably be fine. So in the end, I learned all grafts so I could have the options, but it doesn't mean that my situation or what I'm doing for you is always better. There's certain scenarios where I think it does make a difference, but it doesn't mean that you have to go to somebody that knows how to do everything.
Yeah. Well, it's good to have the option and then be able to weigh that against the patient's needs, their age, their demographics, everything. So that's great. And thanks for the discussion around that. It is a long, we could have a whole, 2-hour conversation just about that. Right. So anyhow, once you've secured your graft, and you've done the basics of the procedure, is there anything that you can do on the orthobiologic side of things that's going to help outcomes? Is there any kind of leading edge technology or recommendations when it comes to using orthobio?
So, I mean, you could sometimes people ask for like a PRP injection with this to try to help with the integration of that. And that's a reasonable thing. There is a lot of good studies and it's not mainstream yet. And it's because these products are extremely expensive. And so no insurance company will pay for these products. And so patients have to pay out of pocket. And it's really not enough data for me to offer them. Yeah. But they do, like, you can have amniotic wraps. So you take the graft and you wrap it in an amniotic coating, which is kind of cool. And there's some data that maybe that helps with integration. There's some other things where they can like grow these things in the lab that they can kind of grow on there. And those are more out there, but I can tell you in the next 5 years, I think this is going to be, more ways that we can make them better because, we can still do a better job at everything we're doing. And you're going to see there's more innovation. Just when we think we know what we're doing, we can get better results, right? Because I would love to have that return to sport be 100%, and it's not currently. And faster recovery too. And that thing. But I don't want to kind of steer your question towards something I'm thinking about. Yeah. But regardless, there is a biologic type of option that I do, especially for quads. So it's called an internal brace. And you guys may have seen this with other different things. Like, there's the Tommy John internal brace type of thing. But what you can do is, and people do this even for patella tendons, but mostly quads, is I put a collagen impregnated suture. And it's like 2 or 3 times the sort of strength of a regular suture. And you can put that in the middle of the graft. And what that does is you don't want to put it as tight as the graft. You put it just a little bit looser than the graft. And that is like a suspension bridge. And there's some data that shows that helps, especially soft tissue grafts, hamstring and quad tendon, to give them that little extra oomph that you would normally get from a bent patella tendon. And I think by doing that, with more recent data, it does help. And I've noticed that my quad grafts and my soft tissue grafts are starting to feel more like patella tendon. And I think that's been helpful.
That's great. So it's kind of like a way to make up for the fact that you're not getting a bone-to-bone connection.
Absolutely, because you anchor it on both sides like a bone-to-bone. You're not using a soft tissue screw. You actually have 2 separate anchors in through the button. And that's innovative, and it's not that much more challenging to add that portion, but I just give someone a little extra. And I do think I've seen results that are improved with this.
Oh, that's great. That's something I hadn't heard of. So
okay, good.
That's great to know that, there's some better options out there. Things are improving. So in this situation where we have this really clean ACL tear and a clean, tidy repair, it seems pretty straightforward in terms of what the recovery process is going to look like. That's easy to talk about. But how does the rehab process, how does the recovery process change when somebody's had a cartilage defect that has been repaired or meniscus tear that's been repaired?
Okay. Let me go through the meniscus one first. That's the one we see most commonly. We do a fair number of these repairs. Meniscus, now everyone's kind of got a little different PT protocol, but this is mine. Usually the first 6 weeks are really the big sort of thing to think about if you're listening right now. After the 6 weeks is not much change in the protocol. First 6 weeks, you're going to be wearing a brace for the whole 6 weeks, not just the first couple until your quads are strong enough. You're going to not be allowed to bend past 90 degrees, and because that puts extra tension on the meniscus. And then usually no weight on the knee, and everyone kind of argues about what to do, but I'm pretty rapid on this, and I haven't seen any difference in the way we do this. But 1 week of non-weight bearing, 1 week of partial weight bearing, which means about 50% of your weight. And I would say people tend to be walking pretty normally by 3 weeks. And that's really the key. And I'll do that for pretty much every meniscus repair, even a bucketed meniscus where I'm putting, 4 or 5 sutures into the meniscus. And that's why I honestly have that conversation with every patient, because sometimes you can't see a meniscus tear on MRI and you don't find it until you're actually in there. And so that's on that conversation I have. And so most patients will get that in my office. Cartilage. This is a tricky topic. I'm not going to go too much detail into it unless we have more time later.
Sure.
But basically, first time cartilage defect, you really actually don't want to do anything with it unless it's a really big deal. So I do a lot of cartilage preservation surgeries, and the data shows if you have a cartilage defect and a first time ACL injury, your surgeon should do nothing with it. Leave it. Okay. Unless it's a monster hole, which is very uncommon. So the number that you need to treat eventually, if they've got a cartilage defect, is like 10%. So I probably have a cartilage defect once a month, and I've had to go back and do another person. I've done this many of those because you just don't need to that often. How many have I done that have had ACLs 20 years ago and now have a cartilage issue, or 10 years ago from somebody else and they kind of had some attempted surgery and everything? That's much higher. I do about one of those a month. And so you got to be careful on what you're doing, because, you want to make sure you start mucking around and doing a small surgery or something, minor surgery to the cartilage or the bone, because obviously the cartilage is gone.
Right.
You can cause further problems. So really it's better to kind of watch it and see how it goes. And if a second surgery is needed in the future for the cartilage, that's much easier to address. It's a lot easier recovery to not have to mess with the cartilage at first.
Great. That's great insight. And yeah, we won't go too deep into that because that is a really complex topic.
I get too excited about it. You don't want to do that.
and lots of exciting stuff happening in that area as well, right? So I think at this point we'll flip over to the rehab side of things. Okay. And now we've got our patient. They've had their repair, they've had their reconstruction. What do you think are the most important things that they need to be focused on in their rehab, their recovery process? And I'm happy to jump in.
I probably want you to do more of this because you see them more than I do.
Sure.
I would tell people the one I get the most questions about is they just constantly grab their quad. They say, "Doc, why is it down so much?" I think this is more for expectations too. And I think you obviously will do a much better job of addressing this. But, every single visit till like 10 months, it's, why is my quad not full again? Listen, we have all this thing we're trying to do. There's some data showing, should we start giving people growth hormones? I know that sounds scary. It's actually pretty low risk. I don't do it in my patients, but there's some data that shows it's actually really beneficial. Yeah. Some top guys in Michigan are looking at that. And I know we're going to get into this, but there's, I like to worry about hamstrings as well are really important, but I think the quad's a big thing. Mm-hmm. Obviously, I'll let you lead that way, but that's the number one thing I get.
Great. Yeah, and couldn't agree more in terms of early recovery, right? We need to get that quad strength back up. We also need to get your hamstring strength back to a place where your hamstring essentially acts like the brakes for your ACL in many movement situations. And it's that co-contraction between hamstring and quad that basically balance the position of the knee. So just in this bending sagittal plane, that hamstring quad balance and that quad to hamstring ratio is how we refer to it, is really important. But because the surgery and the swelling in the knee and the pain in the knee really act to inhibit quad function, getting pain down in the joint and in the soft tissues is a huge part of bringing that quad back on. So that's a really important early part of your recovery. And fortunately, just in the last couple of years, we have a new tool to address that, and that's called blood flow restriction training. And it's pretty amazing how this works, actually. It's a fantastic breakthrough for our patients because we can take a knee that's fairly painful, where they're having a hard time regaining strength because it's painful to activate the knee and activate the muscles around the knee or activate and load through the soft tissues that have been cut on and are still healing. And we can basically get the same impact in terms of muscle strength recovery and tendon regrowth and recovery out of really light exercise. So we're talking less than between 20 and 40% of your one repetition maximum compared to, so we're getting the changes that you would see in that range that you would see in the 70% one repetition maximum range. So essentially, blood flow restriction training, what it does is we put a tourniquet on the leg. It reduces blood flow anywhere between 40 and 80% is what we consider to be effective and safe. And what that does is it creates a unique set of conditions for the muscle where you get physiologic changes in about 3 to 4 weeks that you would see in about 12 weeks under twice the load. So, the quick elevator pitch for BFR, or blood flow restriction training, is that, you're getting twice the gains in half the time with half the load. And, when somebody's recovering from a surgery, being able to reduce load in the early part of the rehab is really key, because you're going to have way less muscle atrophy. So you're going to lose less strength, and you're going to gain in hypertrophy. You're going to grow muscle back at a much faster rate, because just being immobilized for as little as a few weeks causes a lot of muscle atrophy, and that's one of the biggest things that we're combating. So I would say that's been a game changer in surgical rehab and most rehab in general, even soft tissue injury rehab, and has been a tool that we've been utilizing at Union for about a year now. So after that, in terms of return to sport, once somebody has regained their strength and the strength is comparable to the other side, now it's a matter of taking those resources that you've built and then being able to use them effectively. So then we're looking at things like proprioception, which is basically relearning where that joint is in space. The ACL is a really important mechanism to not only stabilize the knee, but to also provide input to the muscles that control the knee. So when you apply stretch to that ligament, the ligament has sensors in it called mechanoreceptors that then feed back into the muscles that protect the joint to say, hey, I'm under stretch, I'm under load. I want you to react in this manner and in this coordinated fashion, like a little more quads, a little less hamstring. Okay, that's just right. Now we're nice and safe again. So when you've taken away that proprioception and you've put in a new graft and the body's rebuilding this structure, you have to rebuild that connection to your brain. So that falls under this category of kind of dynamic control or neuromuscular control, which is hugely important, because you can have a very strong patient who recovers their strength very well, but you take them through some tasks where they have to fire muscles either more rapidly or in a more coordinated fashion, and you see them just fall apart in the task. And so we think that that's essential. And so that's where really these sport-specific training programs or return to sport type exercises are really key. And then you're really examining, what the unique demands of this athlete's sport is. If they're a cyclist, there's a lot less to think about in terms of control and planes of control as compared to somebody who is a soccer player or a skier, or they do both, right? Which is super common in our area. So, when we're looking at skiing in particular, within our Alpine Training Project program, we've really singled out the eccentric demands on the muscles and how it's very unique to other types of strength development. You can't just do squats and deadlifts and expect to have good eccentric quad control when you go out on the slope. So we're putting them through landing drills, plyometrics, things where they're going to be working on rate of force development and then how powerful and how much endurance they have while they're taking on those eccentric loads. And so, having realistic expectations about when those kinds of activities are appropriate are really important. So we want, you to have 70% of your strength on the unaffected side, no range of motion deficits, no swelling, and then we can really start to develop some of that sports-specific training. From there, we do promote prehab, and I'm just kind of curious about what your opinions on prehab are, how important you feel that is, and how you work that into your training plans.
I think it's extremely important. I mean, I would say that the majority of my patients, I give it to them. I mean, it's part of I get the classic. I've had 4 this week come in, swollen knee, get the MRI, double check, make sure it doesn't have it. I literally don't even wait for the MRI result. I send them to you guys for the prehab ACL recovery program. The sooner they get you the prehab, the sooner you're ready either to start coping or to eventually have surgery and be ready to go. Your pre-range of motion function, pre-strength beforehand is completely influential on how you do later on. And I have multiple patients I've done the prehab on that have done surgery, and they were like, this is way better than I expected because I was so strong before I started. It's a common miss by surgeons to just gloss over it. It is my biggest trick that I can use to make you do really well. And not everybody, we're not 100% success on our surgeries, but I can tell you I've got lots of those tricks, and that's one of the best ones I could possibly use. And that's why it's so nice having a place like Union that I can refer to, get them in quickly, get them taken care of, know they're going to be ready to rumble. And, in 3 to 4 weeks, if they have to have that surgery, then they're completely pain-free. The key is no pain for most part and good motion. And I think you guys could probably add to that.
Yeah, couldn't agree more, right? Going in strong, you're going to have a bigger, stronger muscle. So the effects of, the surgery and the period of decreased mobility and pain, you're going to have less atrophy. You're going to have less to gain back, essentially. That injury is going to cause your muscles to shrink up. Your control is going to diminish. So we want to load you appropriately. It's really about optimal loading wherever you are in the phase of your recovery. With that said, I guess I wanted to get your take on blood flow restriction training. And, you've seen that come around. What are your experiences with it? Would you say that you've been as jazzed about it as I am, or where do you fall on that?
I'm very jazzed about it.
Cool.
I mean, I get excited about a lot of things because I have do all these fun, funky surgeries too. But the answer is that from a rehab standpoint, it's probably one of my favorite things to send people for.
Cool.
I've seen huge gains. There's a lot of good data on it, especially for ACLs. United does a great job of doing the blood flow restriction. I know you guys mentioned too. You guys have a Australian program that you use.
Yeah, we're using those air bands. It's a Bluetooth technology. It's a little easier in the application.
Well, that's good too, though, because you want to make sure it's easier because the older applications are not as slick. So I a lot of times it's not built into my normal protocol because I want to make sure that the place I send it, like Union, does it. So obviously they do it. So it's a good place that I write, blood flow restriction, please focus on that. And I am all for it. Actually, I get a little concerned when a place doesn't do it because that's really the new thing. You want to make sure you're getting the most up to date. I mean, that's what all the athletes do. If you see athletes, remember Adrian Peterson, I think he was like one of the few that did it at the beginning and he got back a lot faster. I mean, it does make a difference in my opinion. And I think that's why we've been seeing, a little bit better results here or there than we were even expecting with these new technology. And Seattle's so up to date with, places like Union that do it, that's been really influential. But I am a huge proponent. I've actually done it myself. I didn't get injured, but I wanted to know what it felt like. If you're actually big in working out and you actually could do it safely, it's amazing. I mean, the burn you get, I've never felt so weak in my whole life doing a blood flow restriction arm or leg. I'm lifting like 10 pounds and it feels like 50, but you can see how effective it is, right? Because I'm not putting any extra strain on the joint. I'm lifting, 20 pounds and it feels like a max bench or a max press. It's amazing. And that's really the difference. And, very little harmful, or there's really no harmful side effects. It's overall a very safe thing to do. It's just really effective. I mean, you were sore. I was sore for like 2 days afterwards. It was like the best work I've ever had. So I would highly recommend it. Even if you don't have a surgery, you just need to have some good training with a place. It's the way to go.
Yeah, I've experimented a little bit myself, and it's pretty fantastic. Like the hypertrophy gains that you get, the strength gains, the size gains you get, is really amazing, and it is a little bit of a hack, right?
It's definitely a hack. I mean, it's the only legal hack I can think about.
Yeah, exactly. I guess, it's talking about the risks of BFR. One of the biggest ones, right, is to throw in a blood clot, right? And because you're occluding blood flow, and that is one of the risks, right? The risks are very low of actually clotting unless you have, a genetic predisposition towards clotting or a cardiac condition that can cause clotting. In that post-surgical window, is there a period of time that you would really advise against that? And what are your kind of words of caution?
That's a fantastic question. And so we won't go too much into complications of surgery, but we do a lot of ACLs and I do a fair number of these. And so blood clots are common. I mean, we get one a month in a young, healthy person. And the biggest thing is you want to make sure you have a doctor or staff that's really aware. So we have a very high catch rate, and generally it happens in the first 6 weeks. It's more commonly with the non-weight bearing surgery. So, meniscus or something like that. Just a general ACL, it's less common, but I'm almost always catch it in the first 6 weeks. And so I generally don't want BFR in the first 6. I don't know how you guys do it. And hopefully I'm not going against the protocol with that. But I think most PTs don't start it at least until, after that time period, because it's really the first 6 weeks of the major issue. And again, if you get a blood clot, everyone's always really stressed about it and nervous. I mean, I know two of my partners that had it after non-surgical things. It's not as scary as it seems. The biggest thing is you just want to make sure someone catches it, because 99.9% of these are not a big deal. And, you got to see a vascular doctor and they kind of give you medicine and it goes away. But you want to make sure you don't get the one that's the big one. So.
Yeah, absolutely. Yeah. And our protocols with BFR post-surgery is 8 weeks.
Perfect. That's exactly what I would feel comfortable with, because, I don't think I've ever seen a blood clot that occurred after 6 weeks.
Yeah. Definitely good to err on the side of caution. And, with this, we'll start to wind down here and just talk about re-injury, and the unfortunate occurrences of another ACL tear or a tear on the opposite side. What are some things that you try to be heads up about in your return to sport recommendations, and then otherwise as it's concerned to re-injury and trying to prevent re-injury?
So we won't, in the sake of time, we'll try to make it speedy, but I tell people, obviously, it's never your normal ACL. So your chance of re-injury, it depends on the graft you use, but for the most part, well done graft, well appropriate, 2 to 3%. And, everyone can change their numbers on that, but that's what I usually see in the literature. The unfortunate thing is actually the higher chance of re-tearing, and people are always shocked by this, is actually the other knee. Right. It's around 6%. So a lot of people have factors that we can't really have time to go over that makes them predisposed to the ACL injury in general. And so that's how they put themselves at a higher risk on the other side. And the interesting thing is that some of my patients actually come out, and I would never say this is the reason to do the surgery. They actually come out stronger on the knee that we did the surgery on, and they start realizing that their other knee has deficits. And so I think that's part of the reason as well. So it's really important, and I think the union does a good job of this, is making sure that you want to focus on the injured knee, but you got to take the other knee just as seriously, because you want to come out of this completely even and effective, and both at 100% level. What do I do to prevent things? Everyone has bracing discussions, and we could go over this ad nauseum, but I make everybody wear a functional sports brace with any type of pivoting exercises for the first 2 years. We used to try to do 1 year, but there's another article that came out about a year or two ago that shows that 2 years is effective. And I'll be honest with you, most patients just wear it for life because they don't want to go through it again. Yeah. And I think that's really the best thing to do. And I've had a couple patients. I mean, I did a couple people that were like employees, and we did their surgery, and one of them fell like at 7 months, and I almost had a panic attack because I have to see them at work, and they said they fell with their brace on and they felt so much more safe. I think it's a security blanket, and there is data that shows even a brace helps if non-ACL patients in skiing. And so it's really a good thing to have, especially for the post-surgical patients. Yeah. I hope that answered the question.
Yeah, that's a great answer. And thanks for throwing in the bracing aspect of that. On our side of things, there are factors that predispose you to ACL injuries. I mean, 70% of ACL injuries are what we call non-contact. They involve a change in direction over a planted foot. And essentially, it's a neuromuscular breakdown. Something either in your strength or your control mechanisms fails, and that ligament is the failing point. And so we have heaps and heaps of literature that demonstrates that, they're easy to diagnose and easy to address through exercise programs, factors that will then prevent future re-injury. So it's a matter of identifying things like that quad to hamstring ratio, your dynamic knee control, how well you control your knee over your foot in a single leg kind of situation, your hip abduction and external rotation strength, and then how you control your trunk over top of your leg. And there's fortunately a lot of research available, and we've gone through all of it in creating the Alpine Training Project and presenting the material that we've put together and the programs we've put together to our peers out there and some state conferences, et cetera. And so, it's great to know that, public health has risen to the task of identifying like what are the factors that we can prevent. And these prevention programs work, depending on the population you're looking at. For example, in female college soccer players or NCAA Division I, your chance of reducing ACL injuries is about 60%. And in male football, it can go up as 90% in some of these studies. So if you can get between 60 and 90% reduction in your first injury, we know that these same exercises are going to be really helpful in reducing your chance of re-injuring your knee. So that takes us to the end of our time here today. We did want to just open it up. If anyone does have any questions, we've got your videos are muted, but if you just want to speak up, if there are any questions, people are still on the call. But if there are no questions.
Yeah, I've got one. This is Matt.
Okay, go ahead, Matt.
Quick question. When you're talking about meniscus, is there any pain associated with that, or is that something you find, after you open up the knee?
Okay, I'll field this one. So the meniscus tears, there is pain associated with it. So usually we're palpating the joint lines or the joint lines of the sides. Almost always I can predict usually meniscus tears, and that's how I can predict you need it in the OR, because a lot of times the MRI will show a partial tear or maybe not even show it, and then I actually can palpate it before the surgery is, and I know that area is probably, if it's painful around that area, because usually normal ACLs with no meniscus, they don't hurt that much after the first few weeks. When it starts hurting on the sides, that's when we worry about meniscus. So the answer is, yeah, you can predict it ahead of time. Okay. But sometimes you can't. Okay. But the answer is, it's just good to be prepared beforehand.
Very good. Thank you.
Great. Any other questions?
This has been great. Thank you very much.
Yeah. Thanks for tuning in today. And we'll have this posted on our YouTube channel here if you want to go back and reference this later. Just want to, once again, thanks very much, Dr. Garcia. This has been a great event, and really look forward to getting this out there and sharing our conversation.
Well, thank you for having me. It's been a fun event, and I love to hear the PT side of things too, because we spend so much time referring patients back and forth, but we don't get to, talk about each one of our specialties as much. So this has been really fun. So thank you for having me.
Absolutely. All right. Take care.
Bye.